So let's take our first patient, who's a 70-year-old man with 3-week history of malaise, nausea, says his urine looks a little darker, really has no risk factors for viral hepatitis, has not traveled anywhere, no blood transfusions in the past, and no history of any recreational drug use. No weight loss, right upper quadrant pain, ascites, GI bleeding, any changes in urine output. He has he's had long-standing hypertension, degenerative joint disease. He rarely uses alcohol. And his current medications include lisinopril, ibuprofen, and diclofenac. His vital signs are normal. He's jaundiced, he's awake, alert otherwise. He has no stigmata on clinical examination of chronic liver disease. So he has no spider angiomata, pulmonary erythema, gynecomastia. He does not have a rash. His abdomen is soft. His anterior liver span is normal. Spleen's not palpable. He does not have asterixis. Hemoglobin is 10.5, slightly anemic. White count 5,500. Platelets 155,000. AST 350, ALT 550, alk phos 310. So pay attention to these. Bilirubin's up at 5.5, and the INR is prolonged at 2. His albumin is 2.9. So immediately, he has serologies drawn in the emergency room, and he's admitted because he's jaundiced. And his viral serologies, all of these come back negative. So we're asked to see the patient the next morning, and so here are sort of the questions for us. First, what's going on? What's causing his liver to get sick? Is it severe? What's the prognosis? And do we need to proceed to a liver biopsy in terms of management? So yesterday we talked about breaking down our approach into first asking the question, is it hepatocellular disease, is it a cholestatic disease, or is it a mixed pattern? And we talked also about the ratio of the ALT to alkaline phosphatase in terms of how many fold each of these are above the upper limit of normal. Again, if you just look at the numbers, it's pretty apparent if it's predominantly an AST-ALT elevation or alk phos elevation, or both are elevated. And over here, we have AST-ALTs in the 300 to 500 range, so between 6-7-fold to 10-fold elevation. Alkaline phosphatase is in the mid-300, so it's a 3 to 4-fold elevation. So it's a mixed pattern. And the second question we ask ourselves, and this is again related to how quickly the patient could potentially progress to severe liver failure, end up in ICU, where we would need to call our critical care friends and our transplant surgeons to come help us out. So just by convention, acute, any kind of liver disease, or probably most diseases follow this rule. Within 6 weeks, 4 to 6 weeks is considered acute. 6 weeks to 6 months is sort of a subacute pattern, and chronic is more than 6 months. So when somebody comes in with any kind of new onset liver injury, the reason I even make this point is that the acute, the faster the patient gets sick from the onset of symptoms, the faster they tend to recover also. This is sort of interesting. They go down fast, they come out fast. But the longer it takes for them to develop functional failure, that is their bilirubin, their INR, their albumin, these things becoming abnormal, the more dangerous this disease becomes, the less likely it is that it will spontaneously get better. And you need to be thinking that this is a person who may need a transplant. So in this patient, the couple of things are worrisome. First, it's a mixed pattern. Mixed patterns are drug-induced until proven otherwise, as we talked about yesterday. You can have mixed pattern with viral hepatitis. There are some autoimmune syndromes that can do it. But for practical purposes, because that's one of those situations where you could stop the drug early and might be able to reverse the whole process without a huge intervention beyond just stopping the drugs. The second is this is an older patient. So older people who get significant liver injury don't do as well as people who are sort of in the middle lifespan. So very young children below the age of 10, and then elderly patients do not do well when they get acute liver injury. Number two, his albumin is 2.9. That's not normal. The lower limit of normal is 3.5. So what that suggests is even though he has no stigmata of chronic liver disease, he's not cirrhotic. His liver has actually been sick for a little bit of time. And this is not something that just happened in the last couple of days. So the differential diagnosis, when you have this type of a mixed pattern, we always think of drug, but it's always important also to check for other common pathogens such as viral hepatitis. Ischemic injuries in an elderly patient, always possible. We don't know if he had an arrhythmia, dropped his pressure for a period of time, now he's got a bump in his numbers, he's got ischemic liver injury. But the pattern there is usually different. The AST/ALT in ischemia goes up very fast, and it comes down very fast. So again, it doesn't quite exactly fit. Is sepsis a possibility? Well, sepsis can certainly produce a mixed cholestatic picture or a hepatocellular picture, a mixed picture. Sometimes, particularly in, again, very young neonates and in elderly patients, jaundice may be the first sign that a septic event, and the sepsis becomes apparent within the next day or two. So it's in the mix, although this patient's been sick for 3 weeks. If he was truly septic, he would have manifested by now. Overlap syndromes, again, mixed connective tissue disease, PBC, autoimmune overlap certainly is in the mix. And then it's possible that he got an exogenous toxin that he's not even aware of. And of course, he hasn't had a transplant, so we won't consider bone marrow or liver transplant here. So the most common thing is possible case over here. We've excluded the viral serologies. There's nothing to suggest that he's hemodynamically unstable. Clinically, he has nothing to suggest that he's septic. The most likely thing is drug. And he was on Diclofenac and ibuprofen. So Diclofenac is well known to be a hepatotoxin. It's, again, a very commonly used drug. And the risk factors for Diclofenac are NSAID-induced hepatotoxicity. Elderly patients getting multiple NSAIDs, high doses, those are the risk factors. So just to be aware that this can actually produce liver disease and actually can kill the patient if it is not recognized early. Once again, how do we know for sure? Without rechallenge, there's no way to really absolutely be certain, but we don't go there. So we typically look at, things that tell you that, yes, it's suggestive and then possible, but we're not really absolutely certain, but probably best to avoid those drugs. So if the symptoms develop within 5 to 90 days of starting a drug, it's suggestive, and then unless there is a specific drug signature like Augmentin, where the onset of the liver symptoms occur after the drug is stopped, usually if the symptoms occur after the drug is stopped, it's less likely that it's the drug. And then in subsequent exposures, historically, people would rechallenge, but I think in the last 5 to 10 years, pretty much everybody has moved away from these old guidelines. And unfortunately, this is really a gap in the field. These guidelines have not been updated. So in terms of assessing causality, if the liver enzymes rapidly get better after you stop the drug without any other interventions, you're much more confident that's probably what did it. And then, of course, if it takes longer, it's still possible, but there's less certainty about exactly what happened. Maybe it was a virus that you have no idea, yet to be identified virus. There are a lot of them out there. We're constantly discovering new things. So the certainty is less in that kind of setting. But the important point here is if you think it's a drug, you got to stop the drug. You also have to assess the severity. Anytime you have acute liver injury, you got to ask yourself, how severe is this? Because that directly informs whether you need to refer the patient and what is the probability that this person might need a transplant, that things are going to keep spiraling even when you've stopped the inciting agent, and that you might need to get this patient to a transplant center. And so mental status changes is absolutely, if there's any mental status change, that is a very, very serious thing, particularly in an older patient. There are multiple risk factors here already. Older patient, drug-induced injury, albumin is already drifting down. If there's an INR is up to 2, so there is very significant synthetic compromise. And so on top of that, if there's any mental status changes, this should be taken very seriously. So we've talked about prothrombin time. His INR was 2. And so again, a lot of synthetic compromise. Usually, we will not check factor levels unless the patient has got mental status changes, ends up in an ICU, and we're really trying to assess how the patient is doing, literally on an hour-to-hour basis. Liver biopsy, again, has become less relevant in this setting. Most of the time, we sort of know what's going on, and the liver biopsy doesn't really help us. There are occasional cases where you absolutely have no clue. The picture is very, very uncertain. You have no idea what's going on there. Liver biopsy might be helpful. If they do have significant coagulopathy, we will frequently get a transjugular liver biopsy. And there are at least some data that if 50% or more of the hepatocytes are dead, they have necrosis, those patients, the likelihood of spontaneously getting better are very low, and you might as well go ahead and get them listed for transplant. Sometimes you also want to make a distinction between acute liver injury versus acute and chronic. For example, in this patient, his albumin is a little low. You're not absolutely certain if he has some sort of underlying chronic liver disease, because in terms of organ allocation, if you're just acute, you get a much higher priority. You become what's called a status 1. And you get the first organ that becomes available. On the other hand, if you have cirrhosis and you're having an acute decompensation of your cirrhosis, you get a little lower priority. So this may be actually vitally important from the patient's perspective if you do move down the transplant route. So the biopsy, there's a niche indication for biopsies in this kind of setting. Of course, the dangers are you can cause significant bleeding and rarely even death. So this patient actually turned out to have diclofenac toxicity. Just to make you aware that common drugs, just be aware, elderly patient, multiple NSAIDs, suddenly gets abnormal liver enzymes and features of liver injury. Do keep that at the back of your head. So the second case is a 29-year-old lady, who is now a much younger person, relatively asymptomatic, who comes in, who during her pregnancy was noted to have some liver enzyme abnormality. She comes back to see her PCP 1 month postpartum, and at that time, her numbers are rechecked. Her alk phos is 160, AST, ALT are mildly elevated, and then it's repeated again 3 or 4 months later, and they're still elevated. Her ferritin is only about 8, so it is what it is. Viral serologies are drawn. ANA, antimitochondrial antibody, are drawn. Why antimitochondrial antibody? Because this is mainly a cholestatic picture that we're seeing. There's alkaline phosphatase elevation, so primary biliary cirrhosis is in the mix in a young lady. So AMA is reasonable, but it's negative. Ultrasound done because of the elevated alkaline phosphatase to make sure she doesn't have gallstones or something like that. That's also normal. Her prothrombin time is somewhat prolonged, but it corrects with vitamin K. So in this kind of setting, what we have is intrahepatic cholestatic picture, right? We again start with basics. Hepatocellular, cholestatic, or mixed. This is predominantly alkaline phosphatase, so it's cholestatic. We have an ultrasound which does not show bile duct dilation, so it's not a mechanical obstruction to the biliary tree. So it's intrahepatic cholestasis. And of the causes of intrahepatic cholestasis, we checked for primary biliary cirrhosis, and that's not it. So now we need to go one step further and get some tissue to figure out what's going on. So on transjugular liver biopsy, the patient has some steatosis. The patient has modestly elevated portal pressure. By the way, by this time, the ceruloplasmin results come back, which, by the way, anytime you have any kind of liver, Wilson disease is one of the great mimickers. And in a young person with the unexplained liver enzyme changes, always good to get a ceruloplasmin because there is a very specific treatment for Wilson disease, which is penicillamine. And You can essentially prevent all the end organ damage if you catch it early and treat Wilson disease. This patient, incidentally, also got a liver spleen scan because the house staff loved doing tests, and turned out her SED rate was actually pretty high as well.
Were her LFTs normal before the pregnancy?
There are no records of LFTs before the pregnancy. They were checked for the first time, which is not unusual for a young person not to have routine LFTs drawn. So the first time they were checked is midway through pregnancy, when she had some abdominal discomfort. So the question now is, what's going on in this person's liver? What is the cause of her elevated liver enzyme test? What additional things should we be thinking about? So in this patient, as it turns out, she had a young lady, actually I forgot to mention, she's Caucasian. Young Caucasian ladies, abnormal liver enzymes, keep celiac disease at the back of your mind. Celiac disease is another great mimicker. It's relatively common. If you see hundreds of patients in your office, you will see some of these patients. Many of them are relatively asymptomatic, but she had positive anti-endomycin and transglutaminase antibodies. And on a gluten-free diet, she actually got significantly better. Remember, her viral serology, this is cholestatic disease. It's unlikely to be viral hepatitis and all the other things we went through yesterday as primary parenchymal causes of parenchymal liver injury. And typically, if you do suspect, get a positive antibody, it's always good to get an endoscopy and a duodenal biopsy, which has a very classic pattern of lymphocytic infiltration in the villi and flattening of the crypts. So for patients like this who have persistently abnormal, very mild, these are not dramatic liver enzyme abnormalities, after you've excluded all the viral serologies, you asked about alcohol, and you ruled out all of these things. If you then biopsy these patients, what do you see? So this is a study, and unfortunately, these studies are all pretty dated. There's really has not been addressed. This is all part of the classic literature. Nobody has come back and looked at this again in a large number of patients. That bulk of these patients are due to actually fatty liver disease. As you can see over here, 66% of these patients had fatty liver disease. We now know that cryptogenic cirrhosis is frequently the result of fatty liver disease. When you progress to cirrhosis, you lose the fat in the liver. So you have patients who have burnt out cirrhosis, and particularly if they're obese or they have diabetes, almost guaranteed that their disease was started off with NASH. Drug-induced liver disease, again, I keep harping on this because of the opportunity to intervene and prevent a fiasco. There are rare cases, there are about 5% of cases, where when you do a liver biopsy in these patients, you actually find that the liver looks normal. And the prognosis in those patients is excellent. So many of these patients have mild liver enzyme abnormalities for which there's no obvious cause. If their liver biopsy looks completely normal, we generally just reassure the patient and continue to follow them. In a few cases where the biopsy looks like alcohol and the patient swore up and down that they never touched the stuff, then you got to have another heart-to-heart conversation. Sometimes you may have to ask a spouse or a partner or somebody else, but in a subset of these patients, a history of alcohol will emerge. Autoimmune hepatitis usually presents with much more significant liver enzyme abnormality. It's uncommon to see minimal liver enzyme abnormalities in these patients, but there's a small subset of patients where that could happen. So if you look at investigation of persistent aminotransferase elevations of unknown etiology, typically over here, you would check viral serologies. You would check a ferritin alpha-1. So it's a panel, and many hospitals will actually have a chronic liver disease panel that includes all of these. You'll get an anti-nuclear antibody, you'll get the ferritin, you'll get the alpha-1 antitrypsin, ceruloplasmin. And alpha-1 antitrypsin is one of those rare diseases that, once in a while you will come across, but at least need to be aware of. Alcohol, you have to ask the question about alcohol. And, frequently, we as physicians are very judgmental. If somebody has a couple of drinks, we just label them as alcoholic. To produce alcoholic liver disease, you have to consume more than 60 to 80 grams of alcohol consistently for prolonged periods of time. And so it is very easy to blame the liver enzyme abnormality on alcohol. And we frequently will tell patients to cut down or stop their alcohol consumption, but be aware that that may or may not be the cause of the abnormal LFTs. So just telling people to stop drinking may not get the job done. Now, sometimes, if patients have risk factors, it's worth checking for HIV as well. We have seen a whole slew of HIV-associated liver disease, and so sometimes the presenting manifestation in young people frequently can be some sort of liver abnormality. Diabetes, thyroid dysfunction are important. Why? Diabetes is a very important risk factor for fatty liver disease, and particularly the fatty liver disease that is likely to progress to cirrhosis. So it's a very, very important, type 2 diabetes is a very important risk factor for NASH. So we always sort of ask patients about it. Thyroid dysfunction is important because hypothyroidism is also a risk factor for fatty liver disease. And then, of course, if patients are obese or have other features of metabolic syndrome. So this is a study where they took about 1,000 patients who were referred for liver biopsies. And with initial testing, they were able to identify the etiology in about 90% of these cases. And of those that remained negative, upon more detailed testing with PCR-based tests, there were an additional number they were checked for hepatitis B and hep C by RNA, DNA. And a small proportion of these patients, out of these 101, a small number of these patients actually were positive by PCR. So the point here is that when we get these antibody tests, there are some patients who have false negative antibody tests, particularly if there is any evidence of chronic kidney disease or if the patient has any reason to be immunocompromised, the likelihood of having a false negative test is significantly higher. And in those cases, if you really want to be sure, probably good to get a PCR-based, qualitative PCR to evaluate their hepatitis C status. And as you can see once again over here, you can see a whole spectrum of disease, including cirrhosis, with relatively modest aminotransferase elevations, even without synthetic failure. And then over here, if you take people who are quote-unquote labeled as cryptogenic, where you got all your basic tests and everything was negative, and then you actually got the liver tissue and checked for virus load in the liver, then there is particularly in those who have cirrhosis, there's a significant proportion of people in whom you may find the virus. So this is an area of controversy right now because we don't know whether it's a methodological problem because of specificity of the assay in tissue samples rather than blood. And there's argument about if the blood is negative and the tissue is positive, does it mean you've got occult virus, or is this something else going on? Because we also have data that a lot of these patients with cryptogenic liver disease, if they have risk factors like diabetes and obesity, might have fatty liver disease as well. So bulk of the field, despite these data, are sort of, most of the people think that it's really split about 50-60. A lot of these patients have underlying fatty liver disease, especially if they have diabetes. And then in a subset of these patients, you may have cryptogenic viral hepatitis. Coming back to celiac disease, elevated aminotransferases can be seen in up to 40% of patients with adults with celiac disease, and similarly in kids, about 50-54. It may be the only presenting manifestation. So the clinical presentation of celiac disease is not always with abdominal discomfort and diarrhea. And these elevations invariably resolve on a gluten-free diet. The liver histology can show variable degrees of steatosis, inflammation, fibrosis, And in fact, in this one study over here, they took 140 patients with aminotransferase elevations of unknown etiology, and they found that 13 out of these 140 actually had positive anti-gliadin and anti-endomycin antibodies. Split between women and men, 8 were women, 5 were in men, and 12 out of the 13 actually had a biopsy that looked like textbook celiac disease. So actually, we talk a lot about Wilson disease and alpha-1 antitrypsin, but celiac disease is probably more likely to be seen in your primary care clinics and more likely to be missed because people don't often think about it. And if you look at the biopsies in series of patients who have celiac disease, if you do liver biopsies on 40, 50, 100 patients with celiac disease, you get a whole slew of histology from just scarring of the liver with nothing else going on, congenital hepatic fibrosis, massive steatosis, progressive hepatitis. So you can see it's all kinds of things. Primary biliary cirrhosis type picture with bile duct injury, an autoimmune hepatitis-like picture, or even a primary sclerosing cholangitis where the bile ducts shrivel up. So you see the entire spectrum of histology in patients with celiac disease. The good news, of course, is that they all tend to resolve. So in this study, this is a case report of 4 different cases where patients presented either with, where's this thing over here? Acute hepatitis, or they had fibrosis, steatohepatitis, or actual cirrhosis. And in all 4 cases with a gluten-free diet, over the course of 1 year, everything tended to settle down and resolve. And actually, even the cirrhosis stabilized. So remember celiac disease as a potential cause of abnormal liver tests. We have, how much time do I have? 5 minutes?
You have, no, you have plenty.
I got life, outstanding.
But I have a question.
Yes.
So how do we know this isn't benign intrahepatic cholestasis of pregnancy with vitamin K deficiency?
Yeah. So
Corrected and superimposed celiac?
fantastic question. Because the degree of cholestasis did not improve, it remained in the same ballpark. If you have intrahepatic cholestasis of pregnancy, once you deliver the baby, within 4 to 6 weeks, it's supposed to go back to pretty close to baseline. You might have marginal elevations up to 6 months, but you would expect from 180 for it to drop down to 120, in that range. The fact that it did not and persisted suggests this was celiac disease, but certainly in the middle of, if you're seeing this patient while they were pregnant, particularly in the 3rd trimester of pregnancy, which is when benign intrahepatic cholestasis of pregnancy occurs, that would be high in your differential diagnosis. In fact, that's what they thought initially and said, baby's delivered, go back see your PCP, they'll document that your numbers have gotten better, and that's be the end of that. But when it did not get better, they said, well, it's only 4 weeks, come back in a few months, we'll check it again. And when it still didn't get better, that's when all the workup was triggered for this patient.
The other thing was the PG being out and the ferritin being 8 suggests some malabsorption. So is that what led you to the celiac?
Well, it's just having a low threshold because we excluded viral serologies. We excluded all the other common things. So in a young female Caucasian, you always have to have that at the back of your mind. And for her, we actually attributed her low ferritin to just, peripartum, blood loss and iron. Maybe she had marginal iron stores which were not repleted, and she responded pretty well to iron repletion. Everything came back pretty much to normal, but that's, again, outstanding point. So the next case is a 52-year-old African-American woman with a 3-week history of malaise, nausea, and dark urine. She had low-grade fevers, no right upper quadrant pain, no risk factors for viral hepatitis, no alcohol use. She has some hypertension. She's on lisinopril, aspirin, and a multivitamin. Vital signs are normal. She's a little jaundiced. She has some spider angioma and palmarerythema. It's a little bit different than before. She has a little bit of edema, but no ascites, Liver span is 7 centimeters, spleen's not palpable, there's no hysterexis. Once again, her labs are pretty unremarkable, except that her hemoglobin is 10.5, platelets 155. That's not that dramatic, but AST, ALT are elevated. Alk phos, again, you have a sort of a mixed picture over here, and bilirubin is up. INR here is about 1.5, and albumin, again, is slightly decreased. So once again, what this suggests is you got a mixed pattern again. And over here, again, the bilirubin is elevated, so it's significant, it's severe. So we got the mixed pattern. We know it is severe. INR is 1.5, so it's on the threshold in terms of severity. But the albumin is 2.9 again, suggests that there is some chronicity to the process. Regardless of why her albumin came down, she's not completely healthy for some time. Viral serologies, again, the easy stuff is all negative over here. So we again ask the questions. It's always pretty monomorphic in terms of the questions we ask, when we see these patients. What's the etiology? What's the severity? What's the prognosis? Is a biopsy indicated? Because this will then tell us how to intervene in these patients. So once again, we start with the old paradigm of hepatocellular mixed cholestatic. So this patient, again, had a mixed but more leaning towards hepatocellular rather than cholestatic. So remember, we talked about differentiating the acute versus subacute versus the chronic, because that also tells us the likelihood that this will spontaneously get better, because many of these acute illnesses are due to some sort of exposure, whether it's viral or toxin or whatever. And if you remove the exposure, our body naturally heals over time. So if you look at the ALT activity in various liver diseases, with acute injury, they're often, with active ongoing hepatocellular necrosis, they're often much higher. And you'll see that these levels, there are a few of these, and in the old days, they were all sort of given different sort of nomenclature, but here are the ones that sort of are higher. Over here, everything's in the same range, but there are few up here that are higher, and those are the acute injuries that we can see in patients. The other is the AST-ALT ratio, which I alluded to yesterday, because most forms of liver injury, the ALT is higher than the AST. But when the AST is higher than the ALT, you got to think about alcoholic liver disease or the fact that there is some underlying cirrhosis. Now, what is interesting is if you do have underlying cirrhosis and your AST is higher than ALT, or you have alcoholic liver disease, and you get a superimposed injury like Tylenol or something like that, the same AST-ALT pattern is frequently maintained. Just a little clinical pearl. So once again, the differential diagnosis of acute necrosis over here, we again think about drug. There's viral injury, there's ischemia, toxins, Wilson disease, and autoimmune hepatitis. So we've already checked the viral serologies. These are negative. These patients are really not on a drug that is a notorious or well-known hepatotoxin, although theoretically any drug can produce hepatotoxicity. If you're really unsure, and it's always a good idea to hold the drug, try something different. Maybe switch to amlodipine or something like that. There's nothing to suggest that this patient had ischemic liver injury. Always good to get a tox screen to make sure that there is no silent toxin that you were not aware of, that somebody took and were not aware of. And then the reason Wilson disease is important is Wilson disease, when it presents with more of an acute decompensation, there's a 90% risk of mortality, and those patients all need to be evaluated in a transplant center. And then autoimmune hepatitis, because it can present, and autoimmune hepatitis actually has a very specific treatment and can present with a mixed pattern or with a predominantly cholestatic pattern. Now, in terms of autoimmune liver diseases, it's good to think about it as a triangle. At one corner of the triangle, you have classic autoimmune hepatitis, where the AST-ALT, the liver cells, the parenchyma is affected. Then you have primary biliary cirrhosis, where it is the bile passages, the microscopic bile ducts that are the target of injury. And then you have sclerosing cholangitis, where you have the macroscopic bile ducts that are the target of injury. And if you think about it as a triangle, patients can start at any one of these corners, and over time, sometimes the pattern evolves. Some patients right from the beginning are somewhere in the middle with mixed elements of all three components. So the treatment has to be tailored to how many of these components they actually have. So the markers, this patient, so over here, we've excluded viral hepatitis. We can't really attribute it to a drug. No evidence of ischemia. Tox screen is sent negative. Patient had a negative ceruloplasmin. So we're thinking, potentially, could this be autoimmune? It's a middle-aged African-American woman. That's actually a classic phenotype for onset of autoimmune hepatitis. And autoimmune hepatitis actually is overrepresented in the African-American population. So typically, that's the screen that we will get if you're thinking about autoimmune hepatitis. You get anti-nuclear antibody, you get anti-smooth muscle antibody, and the anti-liver kidney microsomal LKM antibody. There's also a soluble liver antigen if you want to be comprehensive, but not necessary for most of the patients. The ANA and the anti-smooth muscle antibody captures 90% of your patients who have autoimmune hepatitis. Autoimmune hepatitis frequently is associated with elevated IgG, so it's worthwhile to get an IgG level and quantify it because, A, it helps you with being more specific with your diagnosis, but if the IgG levels are more than twofold elevated, that's a biomarker of people who benefit from steroid therapy or immunosuppressive therapy. So we frequently will get an IgG level as well. And there are scoring systems that people who write papers on autoimmune hepatitis use. For routine clinical practice, this doesn't really help us. If you have features of hepatocellular necrosis or a mixed pattern and you have a positive anti-nuclear antibody in the right age setting, you don't really need to do all these other manipulations. But based on these, there are scorings that tell us whether you have autoimmune or not. Those are more for putting people into clinical trials and showing that everybody is fairly homogeneous. But it is important to try to assess the severity of autoimmune hepatitis. And that is typically done by looking at the ALT. So if the ALT is more than 10-fold elevated, 10-fold from the upper limit of normal, if the IgG is more than 2-fold upper limit of normal, if you've got synthetic failure, your bilirubin INR is affected. And if you do get a biopsy, there are certain specific patterns where you see regenerating liver cells which form these rosettes, which almost like a flower. And so if you see these rosettes, you see active cirrhosis or submassive collapse, where the entire biopsy looks blue. You don't, on regular hematoxylin and eosin, most of the liver cell is pink, and you get few areas of blue. If it's packed with inflammatory infiltrate and the rest of the liver is dead, that again, these are biomarkers that these patients left untreated have a very high 6-month mortality, and these patients can all be salvaged with aggressive steroid and immunosuppressive therapy. So those are the biomarkers for essentially who you should treat with steroids once you do identify autoimmune hepatitis. So I think I'm at 9 o'clock, so keep the last one for discussion if we have to. Okay, thank you.
So that's what you think this woman
Yes, so classic is a patient, African-American lady in her 50s, presents with a mixed LFT abnormality, viral serologies are negative. So always in liver disease, it's a balance between excluding some common etiologies and then trying to narrow it down. So with a positive anti-nuclear antibody, and so which she had, this fits into the pattern of autoimmune hepatitis, and those are sort of the things that you would check to decide whether to put the person on steroids.